you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
He, got his wrist pain by doing over-aggressive high fives to his buddies.
Hey everybody, welcome back to the Emergency Ultrasound Podcast. This is Mike Mallon here, again with Matt Dawson.
We've got an extra special expert guest edition for you today. This is going to be an awesome podcast for two reasons. One, we're going to talk about a really cool modality that I bet you've never actually done in the emergency department, ultrasound of the scaphoid. And then number two, we've got an awesome guy that's going to be telling us about it. His name is Mark Goodman. I think the best way to describe him is a cross between the face of Val Kilmer, the body of the dude from Wolverine, and the sensitivity of an Enrique Iglesias. He really does have it all. And I think you're going to enjoy his silky smooth voice as well. He is as attractive as he sounds coming through the microphone.
And this is getting awkward, so Mark, would you like to tell us a little bit about scaphoid
I'm
fractures?
a little uncomfortable sitting between both of you guys on the couch right now recording this, but thank you for having me on your podcast. This is something I'm excited to talk about. And actually,
really glad to have you.
Initially got interested in this topic at SAEM in Boston this last year when I went to a presentation from some guys in Boston that are actually doing this as part of their practice, and it seemed like something that we could be doing in the emergency department to maybe improve the care of these patients that we see that present with wrist pain.
Can you do the rest of this in a Boston accent like the guys who were teaching you?
No, I actually don't have a Boston accent. I can do a very poor...
That's right, post-editing.
Okay.
We'll turn your voice
yeah.
What about Jamaican?
Jamaican?
Yeah.
No, I don't have that either. English.
Okay.
No, that's all I got.
Go for it.
I don't know, man. All right,
that's
whatever.
going to be... Let's cut all that part out.
Why?
So let's start with the case. This is a 20-year-old male that presents to the emergency department with pain in his wrist after a fall on an outstretched hand.
My kid, quite the modeling career in high school.
I was going to say, I thought I gave you that gold chain back, but...
Yeah, I want that.
So I'm not sure if you guys have ever seen a patient like this, but this is something we don't see that infrequently in the emergency department. You go in and examine this guy. He's slightly intoxicated. Usually he got his wrist pain by falling or by doing over-aggressive high fives to his buddies in the bar, something along those lines. And he's having pain over the base of his thumb, so you send him down for an x-ray. And you come back and you're looking for any signs of scaphoid or distal radius fracture, and it comes back negative. So at this point, we all kind of know what to do. This patient ends up getting a thumb SPICA splint. They go home and they follow up with an orthopod or with their primary doctor in 10 to 14 days for a repeat radiograph of the wrist to be sure we're not missing a scaphoid fracture. So what I'm going to try and do during this podcast is maybe convince you that we can be doing a little bit more for these patients in the emergency department.
Yeah, let's just face it. I mean, it's not very fun sending these patients home with well, you might have a fracture. We're just going to have to get another x-ray and find out. It's not definitive. It's maybe not the best thing to do, huh?
So as we'll talk about, there's some morbidity. I hope not.
I've died from my scaphoid fracture.
I've seen some bad cast accidents before associated with the mobilization of these things. And, maybe we could...
What they don't tell you about the cast cutter.
Maybe we could spare these patients a couple weeks of mobilization, the lost work, and the complications that go along with that.
Let's do it.
Or actually tell the ones that have the fracture, you have to follow up.
Exactly. So, a little review of the scaphoid anatomy here. The scaphoid sits just distal to the radius. It's the bridge between the proximal and distal carpal row, and articulates with the lunate and the capitate. So a little bit closer look here, that the scaphoid, because it bridges those two rows of carpal bones, when you overextend at the wrist, it's the bone that blocks that overextension. So when you follow that outstretched hand, you're more likely to break that scaphoid, trying to prevent overextension at the wrist. And on the left side of the screen here are the kind of the details of the scaphoid bone itself. And this is more at the level of the orthopedic surgeon or the hand surgeon, and not something the emergency medicine doctor really needs to focus on. This can be broken down. There's all sorts of classifications for scaphoid fractures by proximal, middle, and distal. And then there's also the Herbert and modified Herbert classifications, which I'm sure Matt Dawson uses in another context in Kentucky with how many people named Herbert you know or directly related to. And I think he's a Herbert class 7 right now.
7, yeah. They just had a birth in the family. You're right.
So why this is important is the scaphoid has a distal blood supply. So in order to prevent avascular necrosis of that proximal pole of the scaphoid and prevent the arthritis that goes along with that, we need to find these and fix them pretty quickly. I think we're all pretty familiar with the presentation of scaphoid fractures that we're generally taught. And this is tenderness with axial loading of the thumb, tenderness over the snuff box, which correlates with the waist of the scaphoid, as well as tenderness and ulnar deviation, which is over the distal tuberosity. You can also feel distal to Lister's tubercle, which is on the end of the radius. And if you go just distal of that, you'll hit the proximal pole of the scaphoid. And most of these are sensitive for fracture, but they're not really specific. And I'm sure you've seen a lot of these patients who have pain kind of over their entire wrist, arm, hand, forearm, whole body after a fall on their hand. So it's hard to really pin them down on one particular area.
It's a pretty hard sign to use. If you fall on your hand hard enough to come into the emergency department, obviously you're going to have some pain there. So and I know technically probably there's very tiny places we're supposed to be pushing in a certain way to do this, but I think everybody pretty much, if they're tender anywhere in that general area, splints them. And
yeah, that's the problem, is sort of the medical legal aspect. It's like somebody doesn't have a scaphoid fracture, but you still end up splinting them because, it happens to hurt, in addition to everywhere else on their wrist, also in the snuff box.
So why do we care about this? I think we touched on this a little bit earlier, but immobilizing these fractures early is really a key in their management, and early diagnosis can affect the operative success of repairing these fractures. And you can get the non-union and avascular necrosis later on with a missed fracture that can go on to present with osteoarthritis in the wrist. And negative radiographs initially in the workup are pretty common of people who go on to have a fracture.
That's a lot. 20-25% is a bunch of people.
Yeah, it's pretty scary, especially considering the kind of people who do this. You're talking about the guy fooshing in the bar or the aggressive high-fiving. These kind of guys, these are very hubristic kind of guys who are... if you tell them they have a negative X-ray, they're probably going to take that splint off as they walk out the door.
And if you use the word hubristic, they're definitely going to throw the splint away when they walk out the door.
Hubristic?
It's a real word.
Did you learn that in Kentucky public schools?
Everyone Google it.
How many
and
Scrabble
then
points did you
Mike
get for that one?
How retarded he is for not knowing what hubristic is.
And that also brings up a good point, though, that the prevalence of these fractures in people we immobilize is actually relatively small. Somewhere between 9 and 16% of these patients that are initially immobilized go on to have a fracture, so it's definitely not a majority. And there is some complications associated with splitting these patients, including the lost work, as we discussed, the non-compliance in this patient population, difficulty getting these patients, a lot of whom are uninsured, in to see someone for follow-up, and then the complications along with the continued immobilization at the wrist. So it isn't trivial sending these patients out in 2 weeks of yeah,
you're talking like 90% of the
SPICA.
people that you end up putting in a thumb SPICA are just going to get it taken off, and they just got immobilized for no reason.
Yeah, it's crazy.
It's a ton.
It's a lot of cast padding.
And some other complications associated with the diagnosis is that MRI and CT have really become the gold standard here. So a lot of these patients, if they still continue to have pain at their follow-up appointments, are going to go on to some other imaging modality, which is going to be way, way more expensive than the initial X-ray or an ultrasound. So these are just some numbers I got off the Google. The MRI of the wrist, roughly $1,500, and a CT about $950. So these aren't cheap tests to get. So let's talk a little bit about ultrasound for the diagnosis of these early scaphoid fractures. So the main findings you're going to be looking for: cortical discontinuity, elevation of the periosteum, and then the fusion over the area of the bone.
So show me what we're looking at here, Mark. What are we looking at as far as this cortical discontinuity, periosteal elevation? What kind of craziness are you speaking of?
So here's the discontinuity in the cortex here, and you can see this cortex should be a nice, smooth, rounded area, and there's definitely this little step-off here that's abnormal. That's a sign of a fracture, not just in the scaphoid, but anywhere you're looking. If you're doing ultrasounds of the clavicles and kids are looking for rib fractures, you're going to be looking for similar type of findings. The picture at the bottom left shows a raised hyperechoic line with a hypoechoic fluid collection underneath it, all which is above the normal surface of the bone. This is what's known as a periosteal elevation, and this indicates underlying fracture or injury. So you may be wondering, how am I going to be able to tell a periosteal elevation from a hematoma, from a hemarthrosis? This could be difficult in the ED. And I think the take-home point here is that for the ED doctor, it's really not important to differentiate these when looking for fracture.
if you see any of these findings, which are going to be a hypoechoic fluid collection overlying the normal cortical surface, that's going to be an indicator of underlying injury and going to increase your suspicion for fracture. So how good is ultrasound at picking up early scaphoid fractures in the emergency department? So here's some pretty impressive numbers from 2 studies done by radiologists. They used high-frequency linear ultrasound probes, which most of us are familiar with from our work in the emergency department. However, they used a modality of imaging known as high spatial resolution sonography that not many ED doctors have experience with, and some of our machines aren't even capable of using. So these studies show that we can use ultrasound to diagnose scaphoid fractures, and in a second we'll talk more about a study that's more applicable to the emergency department.
So I got to say, I recently looked this up, and eMedicine, the giver of all knowledge, actually made
After
a statement.
Wikipedia.
After Wikipedia.
Right.
Made a statement that ultrasound isn't really appropriate for diagnosis of scaphoid fracture.
Yeah, I thought it was just basically X-ray MRI.
Do you know? And I looked up and actually had a reference for this, and it was a study published in 1991. Do you know anything about this?
So I did actually look this up when I was doing some research for this podcast and came across this study. So this was a study by Christensen done back in 1991. And what they were doing was taking a 1 megahertz therapeutic ultrasound probe that was placed over the side of the scaphoid. And the idea was that the sound waves would be vibrating the bone and cause pain at the site if there was an occult fracture there. So this wasn't using the same type of ultrasound that we are using now to actually look at the bone and do some kind of diagnostic imaging. And while I try really hard not to doubt anything that I read on eMedicine or on the internet, this would be a lot more like yelling at someone's wrist really loudly to try and see if they have pain over their wrist that would indicate an underlying fracture versus actually looking at the bones of the wrist.
I think everybody listening to this probably understands this, but the probes we use transabdominally are
Higher frequency than that.
Yes, like 3 to 5 to 7 megahertz, and our linear soft tissue probe we're using, is like 12 hertz or so, or around. Just a quick clarification: the high frequency linear probes that we use in the emergency department are actually about 5 to 10 megahertz, not the 12 like I just said. Not that it really matters, but it kind of irritated me when I heard myself say it. So this is unbelievable that eMedicine would use this citation to back up their statement.
So they're low sensitivity there. I'm not sure if it really applies to the same kind of machines that we're using.
They probably
now.
had like 4 pixels on the screen, and they were like, is that pixel black or white?
They ran on an Atari 64 operating system. So.
Well, it was published in 1991, so literally they did these scans in the 80s probably with this machine. So okay.
But I think that's something that's good to bring up, and there definitely is some debate surrounding this, and I wouldn't say this is standard of care in the emergency department at all. This is really kind of a new method of doing things that we're hoping to talk about.
That's all right. We haven't done a lot of standard of care yet on this podcast. So.
So again, what we're looking for is the disruption of the cortex, elevation of the periosteum, and an effusion. And as you can see by that prior slide, those really have a pretty good sensitivity and specificity for picking up scaphoid fractures. So here's just another picture here of cortical disruption. As you can see the correlation with the X-ray findings there on the right-hand side. So,
I'm sorry, Mark, to go back here. So you're telling me that this line right here should be a continuous line.
Yeah.
So what I'm seeing is the fact that the cortex is disrupted.
Exactly.
Is that why you're calling it cortical disruption?
That seems to make,
Awesome. Thank you for that clarification.
And these can be a little bit tricky to pick up initially, so we'll go through some pictures that we did actually on our ultrasound machine later in the podcast here. Here's another example of cortical disruption. As you can see, this kind of nice white line, and then this one area with the arrow underneath it with the break in that normal cortex.
And you got that periosteal elevation there too, huh?
Exactly, yeah.
All right, man, I'm starting to learn this stuff.
And then on the other side, you have a normal side for comparison. Notice how nice and smooth that white line is over the cortex, and then that lack of periosteal elevation or effusion on that side.
Now, this is a good idea. So you can do this like the lung exam and compare the abnormal side to the normal side.
Yeah, I think this slide makes a great point. That with pretty much any musculoskeletal ultrasound, that's the great thing. You can just cheat and look at the exact opposite side and see what it's supposed to look like. So it's something that you're going to do your first one at some point in the emergency department, so I would definitely compare to the other side for the first 10 or 15 of these.
That's unless you're doing a patient that injured himself in a double high five.
A double high
bilateral
five.
wrist.
Double high five accident.
These pictures show an example of hematoma and hemarthrosis overlying the bone. Now, like we talked about earlier, separating hematoma from a hemarthrosis really isn't that important for the ED doctor. A hematoma is generally going to be less compressible overlying the bone, whereas a hemarthrosis will be more compressible. But both of these indicate underlying injury, which should make you suspicious for fracture.
So is this something we can and should be doing in the emergency department, I guess, is the big question now. So I found one study on this looking at diagnosing scaphoid fractures early in the emergency department. And this was done using a high-frequency linear probe, just like the ones we have on our ultrasound machines here. And it was done by a radiologist. And they were looking for the same kind of things we were talking about, cortical disruption and effusion. These patients were followed up by CT scan later, and ultrasound was found to be 92% sensitive for fracture and 100% sensitive for fractures with a high potential of complications. So those are the ones we really care about. So if you can do an ultrasound and tell this patient they actually have a fracture, I think you can give them a little bit more motivation to keep that wrist splint and thumb spica on and actually get some follow-up.
And send them straight to ortho, too. I mean, no like PCP follow-up, nothing like that. Just send them straight to the orthopedist. Maybe even call the orthopedist and be like, hey, this guy's got a scaphoid fracture. Can you see him in the next couple of days? You could really modify their follow-up based on this.
Definitely.
So there's no actual studies of emergency ultrasound physicians doing this, though?
There's not that I could find.
Which is fine. I mean, this is just, there was not any studies of emergency ultrasound physicians doing gallbladder or IUP ultrasounds until someone did it either. So I mean, this doesn't seem like that complex of a scan that we can't learn to do.
So how do you do this scan? And we'll talk about the different views you're going to want to get. You're going to want to start with your high-frequency linear probe and use a lot of gel to help smooth out the inconsistencies over the wrist. You could also think about using a standoff pad, which we've used with like a 500cc bag of normal saline with some gel on both sides, or you could do a water immersion. And the couple times I've done this in the emergency department, I've actually had pretty good luck just with a pretty thick layer of gel with a linear probe over the top of it. The views you're going to want to get are going to be longitudinal and transverse, and you're going to want to look at the dorsal, lateral, and volar aspects of the wrist over the scaphoid. And then you're going to want to be sure to ulnarly deviate these patients so you get a good view of the scaphoid in these views. So starting with the dorsal wrist, you're going to want to start right over Lister's tubercle, which is kind of that bump you feel on the distal part of the radius, and then move just distally to that. The convention with doing ultrasounds of the extremities and musculoskeletal ultrasound is that your probe indicator is usually proximal. So if you're trying to keep things lined up on your screen, that might be a good way to do it.
So probe indicator is towards the patient's elbow.
Exactly, yeah.
Okay.
So here's just a view of that dorsal view. You can see the indicator is up towards the patient's elbow. We're right over Lister's tubercle and have moved to kind of bridge between the distal radius and the scaphoid. And the image we have is there on the right-hand side of the screen. You can actually see the bilobed cortex of the scaphoid right there.
So we're looking at a dorsal view here, and you've got the hand in ulnar deviation, and the probe looks like it's sort of over the snuff box. Is that right?
Yeah, you're going to be actually on top of the snuff box, that the Lister's tubercle bridging over towards the scaphoid. So you're going to be hitting kind of the dorsal aspect of the snuff box in your way over.
Okay, cool.
Here's another view of the dorsal in transverse this time. And this shows the same view of the scaphoid. And as you can see, there's that nice cortex there without evidence of disruption. And when you're looking at these live, you can kind of scan back and forth through this and see how continuous that is.
Okay, so you're talking about this bright white line
Exactly.
here. That's the cortex we're looking at. And then there's shadow all behind it because it's bone and the ultrasound can't penetrate the bone.
Mm-hmm.
And this is just all soft tissue up here and maybe some, looks like maybe some tendons there.
So yeah, you're going to be
Right up on
catching your
top.
extensor tendons coming through this area as well.
Okay, cool.
This is looking at your lateral longitudinal view, and in the picture here you can see that the wrist is ulnarly deviated. Kind of cheating, you can stack some either pads or some towels underneath the bottom of the wrist to really help with that ulnar deviation if the patient's not able to hold it that way. And you get a really nice view here. You can see actually the end of the distal radius in the right in this area, and then bridging over to the scaphoid, which again is that bilobed structure, kind of a peanut shaped, and that nice cortex overlying the scaphoid there. It's the same view in a transverse plane, and again you're just looking for disruptions of the cortex and signs of effusion. The final view is going to be over the volar wrist, or the palmar aspect of the wrist. And this one, you're going to want to start by looking over the flexor carpi radialis tendon. And if you're like me, you probably have a hard time kind of remembering all these tendons of the flexor surface of the wrist. So what you can do is look kind of over the thumb or the radial aspect of the wrist and identify the tendon coming down through that area that's going to intersect right with the base of the thumb. And you can see on this picture down below, tendons have a pretty distinct appearance when you're looking with ultrasound. You can see those nice linear structures coming across the screen, and that's going to be the look of your tendons there. And you can have the patient flex and extend at the finger and at the thumb to see that tendon moving. So this is a view with the ultrasound probe of the volar wrist, and you're seeing the same type of presentation of the scaphoid, that nice bilobed, peanut-shaped cortical structure there. And again, the scaphoid has this bright white cortex, which looks like, in this picture, it's really continuous and there's no effusion. Here's the same view in transverse, which also shows the cortex of the scaphoid through here. So there are a couple pitfalls to watch out for when you're doing this exam. If you have an older person, you can have degenerative changes like arthritis in the wrist that can look like cortical irregularities. Also, ligament sprains or wrist sprains can show up with soft tissue swelling that can look like an effusion. And fractures of the distal and proximal pole of the scaphoid can be harder to view than the scaphoid waist, which is what you're really looking at in a lot of these ultrasounds that we're doing. So I guess the question I have is whether this is something you think we can start using in the emergency department. How I see this fitting into my practice is not really ruling out people for scaphoid fracture, but doing kind of a screening exam early, saying, hey, it looks like you do have a fracture, follow-up is really important, maybe expediting that follow-up by talking with an orthopedist.
Yeah, I mean, I think that's a good way to look at it, Mark. I think that most of the things in emergency ultrasound now, we don't have really good outcomes data on, so a rule out is difficult. I think rule in is something that is a lot easier to pull off. I mean, I guess for me, the way I foresee myself using it is in those patients that I've got a really high suspicion for, and I get an X-ray and it's negative, and I'll try the ultrasound and see if I see it on the ultrasound, and if not, then I guess if they're high enough suspicion, I'll send them to MRI, or I'll just have them follow up with ortho.
Yeah, I mean, we're saying you can't rule it out with this, and that's great. I mean, I definitely think I'll still splint the patient with a lot of pain there, but those were pretty impressive numbers you were showing for sensitivity, 100%. So it would be really interesting to see somebody do an emergency department study to actually see how good we are at this with some pretty limited training, to see if possibly someday we could rule this out and send them home without a splint.
Yeah, when are you going to do that, Mark?
So it's actually in the works right now.
Okay, awesome.
So as quickly as emergency ultrasound is progressing, I don't see this as being really out of the realm of possibility of something we could be doing in the emergency department in the next couple of years once we have some studies showing that we're capable of doing these scans.
I totally agree. The way musculoskeletal is blowing up, I think it's just a matter of time.
All right, well, thanks a lot, Mark. I certainly learned quite a bit and can't wait to use it in my practice.
I learned a couple new words and learned how to do some scaphoid ultrasounds.
Well, thank you guys for having me.
All right, take care, Mark, and thanks for listening again for the Emergency Ultrasound Podcast. We'll be back in a couple weeks.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.